Good afternoon, everyone, and thank you for joining us for the Medical Board of California Midwifery Advisory Council meeting. Pursuant to the provisions of Governor Gavin Newsom's Executive Order N29-20, dated March 17, 2020, this meeting is being conducted via WebEx. Public comments will be heard for each agenda item for individuals wishing to do so. In order to be ready for public comment, we ask that you please ensure that your comments can be heard clearly by connecting to the audio of this meeting through the proper method. If you're having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application, and then select Switch Audio. You will see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you are having audio problems with your device, this will still allow you to participate and hear the audio of the meeting. Please see the instructions on how to connect link on the last page of the meeting agenda for step-by-step WebEx instructions, including screenshots. Thank you, Ms. Holzer. You can now start the meeting. Ms. Holzer, you're muted.
Ms. Holzer, you're still muted. We can't hear you.
Okay, now you can hear me? Okay, thank you. I would like to welcome everybody to the Midwifery Advisory Council meeting. I'm Diane Holzer, the chair of this advisory council. Since this meeting is being conducted via WebEx, I will ask all MAC members and speakers to announce themselves by name before speaking for clarity of the official record. All MAC members are able to unmute themselves during this meeting. Please place yourself back on mute when not speaking to reduce background noise for all participants. Following such online meeting etiquette will ensure the best audio quality for everyone. During each call for comments from MAC members and speakers, we will ensure that all comments that can be accommodated are heard before proceeding with the agenda. Government Code Section 11126.5 allows a board to remove people who willfully interrupt a meeting, to clear the room or virtual space if order cannot be restored by removing or muting the disruptive people. During each agenda item, the host moderating this WebEx event will activate the Q&A and hand-raising features of WebEx, and we'll ask anyone wishing to make a public comment to indicate so by replying yes in the Q&A window or by raising their hand. The host will then call on individuals who indicated they wish to make public comments by name. Called upon, the host will unmute the microphone of the individual and they will be able to make their public comment. After the comment, the individual will be placed back on mute. Please see the agenda for WebEx instructions on how to connect from the link on the agenda and additional instructions. The board's IT staff will assist me with receiving the public comments via WebEx during this meeting. MAC members, as a reminder, during today's meeting, any items requiring a vote will be done by roll call vote. This means that once a motion is made and seconded, Ms. Moriarty will call each of the names individually to request our vote. I would now like to call the meeting to order and ask that Ms. Moriarty please call the roll.
Ms. Ave? Dr. Adams?
I'm here.
Ms. Brelia?
Present.
Ms. Corinne?
Present.
And Ms. Holzer?
Here.
Thank you. We have a quorum.
So now we can move to agenda item number 2, the public comments on items that are not on the agenda. Are there any public comments?
Thank you, Ms. Holzer. I've activated the Q&A window and also the hand-raising feature. You can use whichever you'd prefer to indicate you would like to make a public comment. We will call on you in the order that they are received. First up, we have here Joseph Domingo. Joseph, are you there?
Yes, I am, and thank you so much. Good afternoon, advisory committee members and fellow attendees. My name is Joseph Domingo, and I'm here to comment briefly about the newborn screening program at the California Department of Public Health and opportunities for licensed midwives. The California Newborn Screening Program, or NBS, is a preventative public health testing mechanism for all California newborns after 24 hours of life. We test for over 80 serious but treatable genetic disorders like SCID, or SMA. Our goal is early detection and treatment before these disorders become severe or lethal. State law under CCR Title 17, Section 6505 requires all babies in California to have this test between 24 to 36 hours after birth. All licensed midwives can give a child the best start in life by performing this life-changing test within the crucial time period. We encourage all attendees to visit our program website at cdph.ca.gov/NBS, and feel free to connect with us by email at nbsoh@cdph.ca.gov. If you have questions or would like to sign up as an NBS provider, go ahead and send us another email at nbs@cdph.ca.gov. Thank you for your time, and I yield back.
Thank you for your public comment. Next up, we have Carrie Sparvan. Carrie, are you there?
I'm here.
Please go ahead.
My name is Carrie Sparrow-Von Ham. I'm a licensed midwife. And Rosanna Davis, the president of the California Association of Licensed Midwives, has asked me to read the following statement on her behalf. She's traveling across country today and cannot be reached until Monday. In the meantime, she asks that people please refer questions or comments to her via email at president@calmidwives.org. That's CAL midwives.org. To members of the Midwifery Advisory Council and medical board staff. First, I would like to thank you all for your work in preparing for this meeting and for the medical board's recommendation in support of a licensed midwife board. While CALM and the midwifery community are grateful for the Midwifery Advisory Council, at the same time, we believe it is time to acknowledge that both the MAC itself and the meeting we are holding today represent the very reasons why the time for a licensed midwife board is long overdue. With all due respect, the MAC serves as nothing more than a performative entity meant to placate members of the midwifery profession and the people we serve, and, if we're being honest, to keep us from airing our grievances during medical board meetings. The truth, as we all know it, is that the Midwifery Advisory Council has no authority whatsoever to develop, promulgate, or even influence the regulations that govern licensed midwives in the state of California. The MAC isn't even empowered to set its own agenda. Instead, it must seek approval and permission from the medical board, whose members rarely even attend MAC meetings. While the MAC status as a token committee with no actual power is bad enough, what is worse is that the Licensed Midwife Fund, paid for by the hard-earned dollars of licensed midwives across the state, is being diverted from paying for actual regulatory work to fund meetings like today's. Meetings which do not, and indeed cannot, bring us one step closer to ending the regulatory stalemate that is itself yet another incontrovertible reason why the need for a licensed midwife board is beyond overdue. One of the more uninformed and dismissive pretexts for continuing to stonewall the creation of a licensed midwife board is the idea that we can't afford it. The midwifery profession, we are told, is too small, and a licensed midwife board will cause our fees to become unaffordable. This scare tactic is being used even as our fees are already being increased, all while the California Medical Association successfully lobbied to reduce the proposed fee increase for physicians. Such smokescreens and scare tactics have no place in serious policy discussions. According to the report commissioned by CALM, which includes analysis of budget reports, projected revenue from fees, and the Licensed Midwives Fund existing reserves, a licensed midwife board is more than well positioned to start up and assume operations efficiently and cost effectively. A key component to a fiscally responsible licensed midwife board is eliminating waste, specifically eliminating the wasteful diversion of funds to fruitless MAC meetings and focusing instead on adopting evidence-based relationships, fostering professional development and continuing education, and shining a bright light on disciplinary practices that have resulted in 100% of complaints against licensed midwives being referred to the Health Quality Investigation Unit for full suite investigations. On that note, we would like to thank Senator Roth and business and profession staff for including an amendment to the Medical Board of California's Sunset Review Bill that requires expert reviewers of licensed midwife complaints to have actual training in midwifery practice. While this requirement is itself long overdue and constitutes nothing more than a Band-Aid for a much larger and systemic ill, we are nonetheless grateful for this small step in moving forward. CALM looks forward to the day when it can dispense with token meetings and convene together in the interests of genuinely protecting and serving childbearing families in the state of California. That concludes my remarks. Again, please follow up with Rosanna Davis at president@calmidwives.org for comments or questions. Thank you very much.
Thank you for your public comment. At this time, there are no additional requests in queue.
Moving to agenda item number 3, the approval of the minutes from the March 11th, 2021 Midwifery Advisory Council meeting. Are there any additions or corrections to the meeting minutes from the members? Seeing none, can I please have a motion to approve the minutes from the March meeting as submitted? I will make a motion to approve the minutes from the March meeting as submitted.
I will second that.
Any public comment?
Yeah, go ahead and open the window again for the public comment or the raise hand feature. If anyone would like to make a public comment, please indicate so now. A few more seconds here. At this time, I don't see any requests.
All right, then Ms. Moriarty, can you please perform the roll call vote?
Yes, Dr. Adams,
Approve.
Ms. Brelia,
Sorry, approved.
thank you, Ms. Curran,
Approved.
and Ms. Holzer.
Approve.
Thank you.
The meeting minutes are approved. And then we're going to move to agenda item number 4, the report from the Midwifery Advisory Council Chair. Let's see. Okay, so I attended the medical board meeting in May where our agenda for this meeting was approved, and also Claudia Breglia was approved for her reappointment to the MAC. Congratulations, Claudia. And thank you so much for your willingness to continue with this work on behalf of midwives.
Thank you.
We had also submitted a regulatory language change for wording of the LMAR, which was also approved, and staff is going to have an update on that later in the meeting. Things with the hearings in the legislature regarding a licensed midwifery board have not gone as positively as we'd hoped, but CALM continues to work on this important issue. I'd like to thank Rosanna Davis and CALM for the hundreds of hours of work they've put into this, and look forward to the day that the MAC will no longer be needed because we have our own licensed midwifery board. And that's all I really have for today. Any public comments?
Ms. Holzer, we lost your video. I don't know if oh, there it came back. If anyone would like to make a public comment, the Q&A window and the raise hand feature is still activated. I'll just go ahead and leave it open since we'll be moving through these agenda items. So any point you'd like to make a public comment, please just type anything into that Q&A box and I'll call you by your name, or raise your hand and we'll call you by your name. At this point, I'm not seeing any requests.
Oh, then let's move to agenda item number 5, establishing goals for the Midwifery Advisory Council. And once again, I don't think we need to add any more goals to our plate unless any of the members have something burning that they would like to have us address at this point. Hearing none, is there any public comment on this?
In the Q&A window and the raise hand feature is activated for anyone wishing to make a public comment. Give you a few seconds here to. I'm not seeing any requests, Ms. Holzer.
Okay, so we're going to have a quick meeting today. We're going to move to agenda item number 6, the report from the task force and discussion regarding Medi-Cal related issues. This has my name on it, but it should be Ms. Corinne.
Yeah, so I took some time to look into some pressing issues across. It looks like there was a report done by Ms. Dugan back in the past with what was facing midwives in the state of California in relationship to accessing Medi-Cal as providers. And I'm just going to bring that up real quick. From my own personal experience and all my discussions with fellow midwives who currently are either seeking access to Medi-Cal or already Medi-Cal providers, everything that was in Ms. Dugan's report dated December 2nd, 2019 still stands as a barrier to access for us midwives. Such issues as there is currently no licensure process for birth centers that are owned by LMs in the state of California, which according to CDPH is a requirement for facility fees in some of the health plans. Another issue that has been pressing with midwives is that managed care plans are requiring a 1 million, 3 million malpractice coverage when Medi-Cal itself only has a requirement of the 100, 300, making it a little bit less affordable for midwives with small practices to access to go through the credentialing process with the managed care plans. And then there is just credentialing in general. A lot of the managed care plans are very uneducated about our licensure and our scope of practice, and it has really slowed down or inhibited midwives from completing the credentialing process through the managed healthcare plans. Those are the top 3 things that I'm identifying as our biggest hurdles with access to Medi-Cal for midwives. There's definitely some billing issues going on with midwives not getting paid, again, because they're not able to contract with the managed healthcare plans, which are kind of just denying claims based on they don't really understand our scope of practice, or that the fact that we are providing services to beneficiaries in the Medi-Cal plan. Does that make sense? I'm not sure. That's what I gathered so far. I don't know if I was the only one that was, Claudia, did you have anything to add to that?
The only thing that I have to add to that is the continuing practice issue of Medi-Cal physicians refusing to do VBAC and then terminating Medi-Cal patients from their plan and refusing to see them when they learn they're desiring a home birth, and then not deleting themselves as that person's provider from the Medi-Cal rules. So when we get to a point in pregnancy where we need to access medical care or services such as ultrasounds or lab work, the client has nowhere to go because it takes time to change a provider on patient request if the physician hasn't terminated them officially, leaving our clients with the inability to get things like emergency ultrasounds or necessary lab work because their physician of record won't see them since they're planning a home birth. I'm sorry, I didn't state that very clearly.
I'm unclear, actually. Just, are we talking about beneficiaries assigned to Medi-Cal in general, or ones that are assigned to managed care plans?
So if you have a client who is cash pay because she's Medi-Cal, and either the midwife isn't a provider, or for whatever reason, usually because they're not a provider, if that client tells their Medi-Cal physician that they are planning a VBAC or they are planning a home birth, then what quite frequently happens is that their care is terminated. They are escorted out of the physician's office and told not to return. However, the physician doesn't terminate them officially as a patient within Medi-Cal. So, for instance, if a client needs an ultrasound to rule out preterm labor, or for whatever reason they need additional services not included in the midwife's fee, they can't go back to their physician because they've had their care terminated. And when they call Medi-Cal to get a different physician, Medi-Cal says, oh, that's going to take at least a month because you're still on the rolls with this physician.
So that means you're talking about managed Medi-Cal plans.
I guess, yeah. Yeah, I know that when I was in LA, in the Valley, there were absolutely no Medi-Cal physicians who would do vaginal birth after cesarean. So it didn't matter whether they were in managed care plans or seeing individual doctors, whatever doctor they were assigned, that's who they have to go to. And that doctor has to terminate them, or they have to request a change in order to get a different doctor. If the doctor is refusing to see them, then they have nowhere to go. So they have to pay for things out of pocket that Medi-Cal should cover.
So the issue then is that it was taking Medi-Cal too long to change the PCP, basically. Which is interesting because, you know, I work in a rural healthcare clinic and we can change a PCP in one day.
Correct. However, you are a provider. The issue is that providers are refusing to see patients. However, they're still claiming them as patients under managed care. So they're continuing to get paid for this being one of their patients. However, they're refusing to see them, so we can't access care through any other Medi-Cal provider.
But the patient or the client can call up and change her PCP anytime, right?
She can, however, if she has an assigned physician who hasn't terminated her care, there's like a time period during which that can be done. Like it happens at the beginning of the month. So I believe if you're a provider, you can call and say, we want to switch this person to us. I don't know how it works. I've never been a Medi-Cal provider. I just know I had a number of clients where I paid out of pocket for emergency services that I needed in order for them to be safe in midwifery care, or that they had to scramble and pay for if they could. Because, you know, and with me calling Medi-Cal on their behalf and being told there's nothing we can do because her provider is still listed as her provider. And so she will have to go through the process of choosing a new PCP at the beginning of the month.
So in this instance, it is Medi-Cal has made pretty good strides in access for pregnancy care. Beneficiaries can call Medi-Cal and request an expedited change of primary care provider. The issue becomes is when if they've seen their provider in that month, in that calendar month. So if she sees the OB, the primary care provider, on the 2nd of August, then they have billing rights to that month. So I think that I personally, as a provider, make it the responsibility of my clients to drop their primary care provider if they're no longer going to be supporting them. If they have an OB provider, it's very different for me because I am a credentialed provider in the network. So my clients don't have, an OB that they are seeing. They are assigned to me in the system, and they're assigned to the managed care plans that I'm credentialed with and in network with. So, but whenever I need my clients to switch into that network, it usually is a 24 to 72 hour process, as long as they have not seen their previous provider in that calendar month.
Okay.
And clients also have the opportunity, beneficiaries have the opportunity to switch to straight Medi-Cal and to pull themselves out of their managed care plan so that they can access care from any provider that provides maternity services. And that's with the managed care plans, you'll need to be credentialed with them, but in Medi-Cal, the Medi-Cal system, if they're in straight Medi-Cal, then any provider can order an ultrasound or lab work.
Okay. Is that always that option? Because is it always an option? I remember at one point, and again, I've not dealt with Medi-Cal, that all clients in, I believe, Yolo County were required to be in a managed plan, and there was no option for pulling themselves out of that.
That might be the case in certain counties, but I don't think that, again, I'm going to say that in the last 3 years, when midwives have been, really coming into the managed care credentialing process, like there's been a lot of us that have been coming in and getting credentialed. We've been seeing down here in LA County, we have not seen a problem with that, where clients can switch back and forth very easily. I don't know for up where you guys are at. I would have to, again, it'll probably revert back to the care plans not being educated in the process, probably just going back to what they used to do and not really seeing that. I also see that even in health clinics that across the board, a lot of women are being denied access to maternity care when that is strictly in the rules that they should not be, without referrals, without prior authorizations and stuff like that. And it's stated in Medi-Cal rules that, and regulations, and Medicaid as well, federally and statewide, that women can access all maternity services through Medi-Cal without a prior authorization or referral to a maternity care provider from their primary care provider. So when you start hearing from managed care plans or straight Medi-Cal, those representatives that are talking to either providers or to beneficiaries on the phone, they're probably giving bad information and not current information based on what I'm hearing.
Good to know.
Does that make sense?
Yes.
Because that is in the rules. That's in the Medicaid rules. That was part of giving more women access to maternity services across the board, that they would not have referrals and authorizations as a barrier.
Okay. Thank you.
I'm not sure what else or what we can do from here. I would love some input, whether or not we or I can implement some kind of survey across the state for midwives to really find out what midwives are struggling with right now, and maybe just start. I don't know what our role as the MAC is in this issue. Are we just bringing issues to the medical board? Are we actually developing a committee that will move forward on trying to find solutions, maybe contacting DHS and finding ourselves some contacts to start conversations about how we resolve some of these issues.
Well, I just have one question. So Medi-Cal requires 100,000, 300,000 in their insurance, and yet the managed care providers are requiring 1 million, 3 million. So it seems that that's a conflict. And where would, and I know this is only one issue, but where would we start? It seems that what the managed care companies are doing is increasing the requirements, which should not happen. So that because it creates difficulty in access to care. I don't think that that's a medical board issue, though. I don't know where.
I agree. I think that we need a DHS representative, like a liaison that we have contact with, who can help us go through these credentialing issues, because this is exactly what's happening with, Medi-Cal in each county has divvied out to managed care plans resources for Medi-Cal. And when we apply as providers to those managed care plans, I have not seen a single one that did not require the 1 million, 3 million coverage for credentialing. So maybe if we had a DHS representative, this might be an insurance commission complaint as well in some aspects. Yeah.
Well, is it under the purview of this? That's the problem that Rosanna Davis was mentioning as far as the purpose of the committee and the ability of this committee to do anything. Is it under because we are under the Medical Board of California. So if the Medical Board of California doesn't have any power in this area, then neither do we, I believe. I don't know if I'm speaking incorrectly, but I think that it may be something outside of this committee.
That particular piece of all of these various issues that Ms. Curran has brought up.
Correct.
I believe that's probably true, but there's many things in here that we might be able to tackle, such as maybe just even something as simple or seemingly as simple as educating the healthcare organizations about who we are and what we do on more of an official level from the medical board or something like that. But maybe like Ms. Curran suggested, maybe a survey of the midwives to find out what would be the most pressing of these things for us to tackle might be the first step. I'm not sure. What do you think, Tisa?
Well, if we talk about access for midwives, they kind of all fall together. Now, educating the healthcare plans directly relates to getting credentialed properly. Also, if they were educated in our scope of practice and we were getting credentialed properly, maybe some of the other things would fall in line, like the malpractice. But I do agree with Anne that there is some inconsistencies with the two applications, where the managed healthcare plan is calling for a higher level of credentialing than what Medi-Cal calls for. So that's, I never thought of it that way. So I'm kind of stuck on that right now. And I feel like that's possibly, maybe that's something for Calm and the lawyers to look into.
It does seem like it should be maybe even, like you said, an insurance commission issue. It doesn't seem right or fair.
Well, I think the only approach is access to care for the Medi-Cal clients. That's the only, I think the only way it might at some small level be interest the medical board.
This
if
is
you're looking at a consumer protection agency, how is that? How is denying them access? How does that affect them?
this is Carrie, and as a starting place for this committee, I think you need to look at the statutes that apply. It could be that the statutes set minimum requirements for liability insurance, but don't bar the insurance from demanding more, or the managed healthcare plans from demanding more insurance coverage.
That could be true too. So I agree with Anne. I think that taking an approach of access to care is what we're mainly concerned about from our standpoint as well, because many of the statements that were made about improvement of maternal health were based on access to care. If like Miss Claudia said, if women are being denied access to just very basic lab work and ultrasound work because their primary care provider will no longer see them based on some decisions that the client made themselves, then we've got to figure out how we help. I mean, I don't know. Like I said, I don't know what our scope is here, but finding, maybe communicating to the medical board that a lot of clients are not getting access to their benefits through their plan because of the lack of care from the primary care provider that has dropped them.
I think one approach that you could try is determining where the problem is. So if there is a statutory barrier to being able to change providers, identifying that, or a regulatory barrier, or some policy issue that doesn't allow people to change providers within a reasonable time. That's something, if you can identify and propose a solution, that might be a way to approach this with the medical board.
Oh, good idea. So, Carrie, when you're talking about, again, the statutes and the regulations, and we're talking about the Medi-Cal program, it's huge. So, and I assume, just like most of these, this is public information, correct? On the medical board website? Or on
The statutes and regulations are on, I use LegInfo website for
Okay.
statutes. Regulations have their own website.
Tisa, do you want to meet as a committee in the next couple of weeks and figure out what all of the statutes are that we need to look at, and then make a plan for finding where in statute these issues are so that we can address them more specifically?
Yeah, if that's our role, is to do that. Yes, let's do that.
And if Ms. Holzer allows, I'm willing to help you on that.
There's just a limit to the number of people who can be involved. So a task force with 2 people can meet and talk about it without violating the Open Meeting Act.
Right.
Can Tisa and I meet and then send Dr. Adams some laws to look at? Or is that
No, that unfortunately that's a serial communication and it's not permitted, but you can obviously discuss it during an open meeting.
Okay.
Okay, so what do we need to do to move forward with just arranging for a task force meeting?
You
Well,
guys
I
can
think,
just do it on your own. We don't
Okay.
get any direction from us at all. But we would want to make sure that we put, discussion and possible vote on something that you might propose for our next meeting, just so that we have a placeholder for it.
Okay, great.
But I think that's a good place to start, a great place to take a look at the statutes and then see and think of anything else when you guys meet, bring that forward too. Thank you so much for starting this boulder. It's been a big boulder on our plate for a long time and haven't had the bandwidth to address it. So thank you so much. So we do have a public comment on this item. So Sean, maybe you could open that up.
And Ms. Holder, I was going to take the opportunity when we got a little break. Can we try switching to your phone audio? Do you have a speakerphone available? At multiple reports, people, I think, not using headsets are having a really hard time hearing you. So
Sure, just a regular landline speakerphone.
yeah, if you have like a home phone or your cell phone that's speakerphone capable, I'll walk you through how to do it real quick. We'll get your audio hopefully improved.
All right, let me grab it.
And then we can take that public comment. Sorry, everyone. That's I think it'll make the rest of the meeting a little smoother though.
Okay, got it.
Okay, so down at the bottom or at the top, maybe at the top of the WebEx window, you see the audio and video option. Or maybe a ellipsis button down at the bottom of it, either one of them.
Switch audio.
Yeah, we want to go to switch audio, and then there's a call in option. If you hit the view button next to that, it's got a phone number and some numbers you can go ahead and call that number it gives you and punch in those attendee ID information and stuff like that, and it'll switch your audio over here. Let's just take a minute to do this and see if it works better for everyone. Okay, Ms. Holzer, it's switched over now. On your computer, go ahead and use the mute button to unmute yourself, and let's see how your audio sounds better.
Okay, does that sound better?
Much clearer. Yeah, thank
Okay.
you. So you can still use the audio controls on your computer to mute it and just put the phone in front of you and make sure it's on speakerphone.
All right, doing that. Thank you so much.
So we'll go ahead into the public comment now. We have Madeline Weisner. Madeline, let me open your line. Are you there?
Hi there. Can you hear me okay?
We can, yes, please go ahead.
Cool. My name is Madeline Weisner. I'm a licensed midwife up in Sacramento, here in Sacramento County. And I am a Medi-Cal provider here. And I just wanted to share a little bit about some issues we're experiencing here in Sacramento. As Tisa mentioned, there's a lot of inconsistency with the managed care plans. We are a managed care county with like a revolving roster of plans, as well as IPAs and medical groups that care is further delegated to. So at any time we're, I'm corresponding with like 12 different payers just to get our clients some care. Whereas next door in Yolo County, they're a single payer county, as Claudia was talking about. So all of their county residents have partnership health plan. just by default can't go into straight Medi-Cal. So even in this region, we're working in like 7 counties with different rules for their managed care plans. And it is quite exhausting, but I think I kind of have figured a lot of it out. The biggest real barrier to care that I'm seeing from my clients is that other midwives are telling them things that are not reality about Medi-Cal. And so at my organization, my nonprofit education organization, I have really channeled a lot of my time into training other midwives about Medicaid laws so that we can follow them together, and increase actual access to this care for our poor and working class families in our region, right? So I do billing training through Quorum. Any licensed midwife in California can access this. Anyone in California can access this. Just send me an email, so that we can all just have a basic understanding of billing in general, but certainly Medi-Cal billing. No Medi-Cal member should be paying out of pocket for their labs or for their ultrasounds. This is absolutely inappropriate. And I think that if the medical board heard of this happening, they might be deeply concerned or motivated to, smooth that so that more of our patients can get evidence-based care, right? So that's my piece. I'm also seeing a lot of the health plans, particularly Partnership, which is the only health plan for Yolo County, just they don't even have credentialing criteria for licensed midwives. Like they go through the whole process and then they're like, oh, we don't have that page in our credentialing book, so we're not going to do it, right? Which leaves our clients in that entire county not able to receive licensed midwife care, right? Or out of hospital birth. So yeah, just wanted to share a little bit about what we're experiencing up here. And I'm always happy to provide insight on that further.
Great, thank you for your public comment. This time I don't see any other requests in queue.
Okay. I'm a little confused with something Madeline just said, that how could Partnership not have, if midwives are eligible to take Medi-Cal, does that mean just Partnership doesn't have a credentialing criteria, or is that county by county as well?
Would you like me to bring Madeline back on the line?
Or if Tisa knows.
So that sounds like a problem that should be addressed, and I would encourage the consumers to really reach out to probably the Insurance Commission about that, because for the state of California,
Insurance Commission doesn't regulate Medi-Cal, you fucking idiots.
Madeline, I'm sorry, your line is open.
So the Medi-Cal has put criteria forward to state that licensed midwives are providers that all healthcare plans should give access to. So if that, I mean, I can't make a health plan do anything. So we need to find the people that are going to bring up the fact that that Partnership is not meeting the criteria that Medi-Cal has put forward themselves, that they haven't. I'll have to look up the ABL that was put out, and I know we have a copy of it here somewhere, or the all plans letter that stated that all managed care plans need to provide access to at least one CNM and one LM within their network, either as credentialed providers or out-of-network providers. So if they don't have a credentialing program, that sounds like they are defaulting on their contracts. Which I'm sure Madeline is very aware of, and that's probably the problem that she's having. I am acknowledging that. And that's something that midwives across the state are having a problem with. And none of us as single practice providers have any time to deal with that problem personally, right? We're busy taking care of clients on a day-to-day basis, 24/7. So being able to take 4 hours out of your day and make a phone call to a managed care plan and argue with them about the credentialing process actually hasn't solved anything in the last 3 years that we've been trying to accomplish this. So the only reason I bring up the insurance commission is that I was on a phone call earlier this month with Oregon midwives who really got some huge waves made in their state by involving the insurance commissioner, because the insurance commissioner is a third party company that makes insurance companies uphold to their contracts. So it may or may not be the route that consumers will find some resolution through. But I think if enough people started raising a red flag in that county with partnership, which I've heard many stories about from other midwives having problems and many clients having problems accessing care through their insurance, that someone will have to start paying attention. And then again, getting some kind of contact through DHS to make them aware of the fact that there are inconsistencies with that managed care plan, especially if it's the only access that those beneficiaries have to Medi-Cal benefits. If their only access to medical benefits is through partnership, then partnership probably needs to be held accountable for having those access barriers.
There's a lot. There's a lot to do. There's a lot. Okay. It looks like there's no other public comments. So just to reiterate what our current strategy is that Tisa and Claudia are going to meet and take a look at some of the statutes around Medi-Cal and see if there's something that we can get an angle with at that, and maybe just do some conversations and gelling around what might be the best chunk that we as the MAC can work on and maybe improve for midwives. Does that make sense to everybody? Okay, so we will look forward to revisiting this at our next MAC meeting. Okay, so moving on to agenda item number 7, update on the proposed regulatory language for the licensed midwife annual report. Ms. O'Connor?
This is Carrie. I'm actually happy to just give the update on this, that the MAC authorized proposed language that would add a new section to the board's regulations. And if you turn to agenda item 7 materials, you'll see the proposed language there that basically would add an additional reporting requirement for licensed midwives to include their client's race and ethnicity as identified by the client as part of their annual report. So this was taken to the medical board meeting in May, and the board approved staff to move forward with preparing the necessary documents to submit to Department of Consumer Affairs and agency for their review and approval, and then it would go to the Office of Administrative Law for notice in the 45-day public comment period. And so I know licensing staff is going to be assisting with the initial document preparation, and we'll move forward with it.
Great. Any questions or comments from the members? Any public comments?
The Q&A window and hand raising feature is still active. If anyone would like to make a public comment, please indicate so now. This time I'm not seeing any requests.
Okay, then we can move on to agenda item number 8, update on midwifery-related legislation and sunset review process. Mr. Bone?
Good afternoon, Madam Chair and members. This is Aaron Bone, the Chief of Legislation and Public Affairs for the board. As you may know, there's been quite a bit of activity in the legislature since the MAC's prior meeting. The board had 2 sunset hearings before the legislature. The first on March 19, which was focused on enforcement matters, and the second was on May 5, which was centered on licensing and related administrative topics. Following those hearings, the legislature amended Senate Bill 806, which is the bill that will extend the sunset date to for the medical board, the osteopathic medical board, the podiatric medical board, and the physician assistant board. All 4 boards rolled up into one bill. With regard to licensed midwives, Senate Bill 806 does the following. It authorizes the board to end the use of paper-based initial licensure and renewal applications. That's something across the board for all license types. It increases the initial licensure fee of LMs from $300 to $450, and the renewal fee from $200 to $300. This would be effective January 1 of next year. States that all licensees of the board would be required to have an email address and report it to the board no later than July 1, 2022. Prior to referral to the field for investigation, the bill requires quality of care complaints involving licensed midwives to be reviewed by a medical consultant with education, training, and expertise in midwifery. And as noted by a previous speaker, the bill unfortunately does not provide for the creation of a licensed midwife board. The author of SB 806, Senator Roth, in a statement that he made during a hearing on the July 14th hearing for SB 806 in the Assembly Business and Professions Committee, he did indicate concerns with the costs surrounding the creation of an LM board and the fee amounts that would be necessary to support that new board. But hopefully that will provide further opportunities for the discussion of a new board, and I'm optimistic that those will be able to continue in the future, and hopefully those concerns could be addressed. Senate Bill 806 is pending a hearing before the Assembly Appropriations Committee, which is scheduled for Thursday, August 19. Following that, I expect the bill to be approved by the Assembly at the end of August or early September, followed by final approval from the Senate no later than September 10. In addition, there was one other bill that I wanted to share with the MAC, and that is Senate Bill 65, which is referred to as the California Momnibus Act. It's in the bill, I assure you, the Momnibus Act. Among other provisions, this bill would require the Office of Statewide Health Planning and Development to establish a program that contracts with training programs for certified nurse midwives and licensed midwives to increase the number of students receiving a quality education and training. That agency must contract with programs that train midwives that have or intend to create a training component for medically underserved multicultural communities, lower socioeconomic neighborhoods, and rural communities. Further, those programs must be organized to prepare program graduates for service in those neighborhoods and communities, or otherwise seek to recruit and retain racially and ethnically diverse students, underrepresented groups, or people from underserved or historically marginalized communities. That concludes my prepared remarks, Madam Chair. I'm happy to answer any questions.
Are there any questions from the members? Sounds like not. Are there any public comments?
The Q&A window and the hand raising features are available for anyone wishing to make a public comment. A few minutes here, a few seconds here to use one of those options. I'm not seeing any requests.
All right. You've been very busy, Mr. Bone. Thank you so much.
My pleasure, Madam Chair.
Moving on to agenda item number 9, the program update from Ms. Moriarty.
Thank you. Please turn to page 9A1 for the midwifery program licensing statistics. In the third quarter of the fiscal year 2020-2021, the board received 10 new applications, issued 8 new licenses, and renewed 70 licenses. In the fourth quarter, the board received 13 new applications, issued 15 licenses, and renewed 56 licenses. As of July 1st, 2020, there were 481 renewed and current midwifery licenses. Please turn to page 9B1. In the third quarter of the fiscal year 2020-2021, the board received 71 transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives. In the fourth quarter, the board received 67 transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives. Please turn to page 9C1 for enforcement statistics for licensed midwives. In the third quarter of the fiscal year 2020-2021, the board received 7 complaints and referred 0 for investigation. In the fourth quarter, the board received 10 complaints and referred 2 for investigation. Please turn to page 9C2. The board received 0 complaints in the third quarter and 1 complaint in the fourth quarter of fiscal year 2020-2021 for unlicensed midwives. Please turn to page 9C3 for enforcement statistics for transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives. In the third quarter of the 2020-2021 fiscal year, 1 was referred for investigation and none were referred in the fourth quarter. Please turn to page 9C4 for the third quarter of the 2020-2021 fiscal year. The board received 3 transfer of planned out-of-hospital delivery to hospital reporting forms for unlicensed midwives. The board did not receive any forms for unlicensed midwives in the fourth quarter. Please turn to page 9D for the 2020 licensed midwife annual report summary. For 2020, there were 545 midwives expected to report. Of those, the Office of Statewide Health Planning and Development received 387 annual reports, leaving 158 licensed midwives that did not report. The total number of clients served during this calendar year was 7,353, an increase of 1,569 from last year. The number of clients who left care for a non-medical reason was 366 compared to 227 last year, an increase of 139. Page 4 of the report indicates the number of planned out-of-hospital births at the onset of labor was 4,776, compared to 3,833 last year, an increase of 943. And the number of completed births in an out-of-hospital setting was 4,050, compared to 3,535 last year, an increase of 515. 3 sets of multiples were delivered out of hospital. Pages 11, 12, and 13 identify the outcomes per county in which fetal demise or infant or maternal death occurred. There were 16 reports of fetal demise, an increase of 1 compared to 2019. And the number of infant deaths increased by 4 compared to 3 reported in 2019. There were no maternal deaths reported in 2019 or 2020. This concludes my report, and I'm happy to answer any questions the members may have.
Thank you. Do we have any comments or questions? So it seems like midwives are definitely delivering more babies. I don't know if that's a reflection of COVID. Well, if no one has any comments, are there any public member comments?
The Q&A window and the hand-raising features are available for anyone wishing to make a public comment. A few seconds here. I'm not seeing any requests at this time.
Okay, then we will move on to agenda item number 10. Discussion and possible action on selection of one public member vacant position on the Midwifery Advisory Council. Ms. Moriarty?
Thank you. In June, the medical board posted a recruitment announcement on its website for one public member position on the Midwifery Advisory Council. This position is for a 3-year term that will become effective August 20th, 2021 and expires June 30th, 2024. The nominee approved by the MAC today will be presented to the board for final approval at the August 19th through 20th, 2021 quarterly board meeting. The board received one application for the vacant public member position on the MAC. The applicant is Monique Webster. Ms. Webster was not able to attend the meeting today to provide a statement. However, Ms. Webster provided a statement to be read by Ms. Holzer on her behalf.
Okay. I can just read that right now?
Yes, please.
Okay. To the Midwifery Advisory Council. I was hoping to join today's meeting, but unfortunately, I'm not available for the latter half when this vacant public member position will be discussed. I served as a public member on this council from 2012 to 2015 and would love another opportunity to do so. I have a master's in public health with an emphasis in maternal and child health and have volunteered as a birth doula. I birthed my 2 children at home with licensed midwives and strongly support this profession. Feel free to contact me if you have any questions. Best, Monique Webster, Berkeley, California.
Thank you, Ms. Holzer. At this time, the MAC may discuss and make a nomination to recommend the applicant for the public member position to the full board.
I would like to make a recommendation to nominate Monique to this position of public member. You just need a second.
I'll second it.
Any questions
Okay.
or comments from the members about the application received? No? How about any public comments?
The Q&A window and hand raising feature available for anyone wishing to make a public comment. Go ahead and indicate so now. Ms. Holzer, I'm not seeing any requests.
Okay. Great. Then, I guess we have to take, do we have to take a roll count on this, right? We've got a nomination and a second?
Yes, that is correct.
Okay.
Dr. Adams,
I'm going to abstain.
Ms. Brelia,
I approve.
Ms. Corinne,
I approve.
and Ms. Holzer.
I approve. Okay, so that will be forwarded to the medical board at the next meeting for confirmation of her appointment, and hopefully she'll be able to join us for our next MAC meeting.
Yes, thank you.
All right, and we will move on to agenda item number 11, discussion on training for MAC members. So this agenda item was actually brought up by Danielle as a new member coming in. She really felt like she needed a little more preparation just for training to be on the MAC. So I'm sorry she's not here today because I really would like to hear what she has to say as being one of the more recent people who came on, although Tisa is also new. There's a lot of different levels, I guess, of training that could happen. I mean, there could just be a packet or a video or, you know, we just went over basic stuff like the Bagley-Keene Act and stuff, but I'm not sure exactly how deep she mentioned all of us getting together on a retreat, but that is not possible due to the Bagley-Keene Act for MAC members to be able to do retreats separate from the public. So we decided to put this on the agenda to discuss about how we might do some training for MAC members. And I don't know, does anybody have any comments on this subject?
Yeah, I suppose since I'm also one of the newer members, I agree that if there was a training video, because as busy providers, we don't have time to read through manuals. And I think that there was, if you could, like you said, Diane, maybe go into depth about can you say that again? The Bradley Keene Act? Say that again?
Mm-hmm.
Ah, so that's something that I'm unfamiliar with, and probably because I haven't had time to read through the MAC materials. Yep, I just called myself out there. So I think as a new member coming in, I'm very unfamiliar with what our exact role is and what it is that we're trying to achieve. Like what can I do with my time here at the MAC that'll have the greatest impact? And instead of, peddling and not going anywhere and thinking of big ideas that really are just not appropriate for this committee, but maybe just finding the outlets that are going to move us forward. And obviously, especially in some of the passions that I came to this board for, like the Medi-Cal stuff. So I don't know if that's a big task for board members to take on, is do some kind of training video. If we could divvy that out somewhere, I don't know.
Hi, this is Carrie, and I think as a new member, you will be offered a time with staff for a training to review the administrative manual, the Open Meeting Act, and anything else that's pertinent. I did do a presentation a few years ago on the Open Meeting Act to the MAC, and so that will be online, and I'm sure that we can assist by sending you a link to that training. And it's possible that we can even coordinate a training with you and the new member that hopefully will be coming on board shortly, because we can do 2 members at a time, and have a further discussion about whether the training may be necessary. But the key is the Open Meeting Act.
I think that's a fabulous idea. Maybe use this opportunity for the new member and myself to kind of gauge what is it that we, as I'm going through the process that you just explained, do I feel like that's sufficient? And just like obviously my own opinion, but I think I'm open to that for sure, getting together and going through the video that you've already provided, as well as getting together with the newest member once instated, and whatever it is that you have already set aside to go through with new members. That would be fabulous.
Yeah, when it sounds like Danielle really felt like she needed some too. Monique has been on the board before, so I don't know if she's going to need a refresher or not, but that would be 3. I guess you can only do 2 at a time. But
Ms. Holzer, the training, Ms. Abe was provided this training, so I don't know if she had something else in mind.
Okay. Well, I think that's a fabulous idea, that what we've got right now, just to, if new members do have time with staff to go over that and can view the video that you did, you did a great presentation on it when you did it. So we can start there for sure. And I don't know, we can put this back on the agenda if we want for next time, so that Ms. Abe can give input into it, since it was kind of her agenda item to begin with, just to make sure we have her input.
Yeah, I agree. Let's put it back on the agenda for the next meeting.
Okay. Anybody else have any thoughts? Any public comment?
The Q&A window and hand raising feature available for anyone wishing to make a public comment. A few seconds here, see if anyone wants to. Not seeing any requests to staff.
Okay. then we're going right on to our last agenda item. We did this quick for future agenda items. So we just said that we were going to put this one back on, training for MAC members, back on the agenda for discussion and possible decision. And then what else? We were going to put back the Medi-Cal task force. We'll go back on, right? Of course, establishing goals is a repeating item. And then all the program updates and the licensing statistics and all the standing items as well. Anything else anybody has? Okay, I think I got everything. Tanya, did I miss something?
Ms. Holzer, I'll go over what I have. And so I have the regular items, approval of minutes, goals. I have the report from the task force regarding Medi-Cal, legislation update, program update, training for MAC members. Are we putting anything on for the LMAR?
Would that's just an update probably, right?
Right. Would you like that on there as well?
I would like that on there.
Yep.
I think we should follow it through.
Okay. Let's put that on.
Okay. That's all I have.
All right. Well, if nobody has anything else, then I guess we can go ahead and adjourn.
You need to ask for public comments.
Oh, sorry. Any public comments for future items on the agenda?
Yeah, and for anyone wishing to make a public comment on agenda item 12, please indicate so in the Q&A box or by raising your hand. Up first here, I have Joseph Domingo. Joseph, your line, are you there?
Yes, can you hear me well?
We can, please go ahead.
Okay. Thank you for the opportunity to previously share. I would like to propose to the board that the California Newborn Screening Program at the next meeting be an item as for presenting more about us and offering an opportunity for members to know more about the program at CDPH. Thank you.
Joseph, I have a question. Are you having problems with midwives submitting newborn screenings, or? I mean, it's a law that all licensed midwives have to do the screenings, and I believe that everybody does them, right? Are you guys having a problem? Is that why you're reaching out?
Yes, and me being the liaison for out-of-hospital births, would like to take the opportunity, I think in the November meeting, to expand, or the NBS program would like to expand on the importance and the necessity for out-of-hospital births, since there was a large amount of out-of-hospital births this past 2020. So if at all possible, if it satisfies all of the committee members, I commend the decision to you all.
Can I make a comment on what he's saying, or are we not allowed to comment on speakers?
I mean, you can discuss it very limitedly, because we want to determine if it's something for a future agenda item. And so if the MAC so desires, we could arrange a speaker from CDPH to come to the next MAC meeting to present on this topic and ask the board that this be an approved agenda item. So if there's discussion around whether this should be a future agenda item, that is allowed.
Oh.
Well,
I guess-
myself, I would think that, you know, most of the licensed midwives anyways are really well familiar with the program and the laws and how to do the program and what the screening does. But if there's issues with out-of-hospital providers not performing the screenings, I would be interested in putting something, something that we can, actually maybe do something about. I would be definitely interested in hearing that. But just an update on the regular program, I'm not sure how helpful that would be to the
I think
MAC.
the hope is to have this agendized so midwives can be educated before there's enforcement action. As a reminder.
I see a lot of misunderstanding, Diane, about what is done with the DNA and privacy concerns. And so rather than the fact that they're required and their importance, because, well, I don't know that all midwives take the importance seriously. But I think they take the privacy concerns much more seriously. So maybe presenting on that and sharing it with Calm for a webinar even. We could put that on the agenda to talk about.
Is that something you're prepared to do, Joseph, or were you thinking more a broad overview of the program?
I think, well, as far as talking about the program, just broad overview, what our department does and how this committee can be helpful in supporting us in getting more out of hospital newborn screenings would be helpful. If that's in the general category of an overview and why is it important, then yes.
Does anybody have a concern with adding this to our agenda next time?
You know what? Maybe we could just add discussion of licensed midwives concerned with the newborn screening program and how they can be addressed.
I mean, I have a suggestion that it be agendized as presentation on this topic so we can have a qualified presenter who's familiar with the statutes and regulations, and then commenters are going to make the comments that they'll make. But it's important that everyone knows this is the law, and we want to support midwives being in compliance.
Well, we can put unless any of the members have a concern with it, we could put it on the agenda. Yeah. All right. Well, so let's add that one to our agenda as well. Presentation from the newborn screening department. And Joseph, I would just ask that if there are issues in particular with the home birth midwives, that you address that in the presentation, because that's where we're going to be interested, because we all know it's a law, we all know how the program goes. But if there's issues getting midwives to comply, then that's where we should focus.
Yes.
Great. So I assume you'll just get together with staff, or staff will find you and figure out how that gets done, right?
I believe so.
Okay, good.
And again, this has to be approved by the medical board as an agenda item. I don't expect it will be an issue, and then we'll assist from there.
Sounds great. Are there any other public comments?
At this time, I do not see any additional requests in the queue.
All right, then I guess we can adjourn this meeting today.
Oh, I'm sorry, one just came in here.
Oh dear, okay. Not yet.
Okay, Madeline Weisner? Madeline, are you there?
Oh, I'm here. I just wanted to request at the next meeting a discussion on engagement for the LMAR, like ways that more midwives could participate in it, just because the next meeting's at the end of the year, and the LMAR is really, really useful in communicating with people about the benefits of licensed midwives. Because our numbers are really good when enough people actually submit them. Also, I just wanted to apologize for my comments earlier. Really unprofessional, really sorry. So yeah, thank you.
Thank you for your public comment. At this time, I do not see any additional requests in queue.
I'm not exactly sure what Madeline meant by discussion on the LMAR. I mean, it's a law, right, that we all have to do it. Does staff follow up to the midwives who haven't done it? I know they have sometimes in the past, and then we realize that some people die, and some people, I'm not sure.
Yes, Ms. Holzer, we do follow up, and I do have some statistics if you would like those, because it gives a little bit of insight. I'll just tell you that delinquent with a California address, there were 35. Current with a California address, there were 448. Delinquent with an out-of-state address, there were 25. And current with an out-of-state address, there were 54. So that gives a little bit of insight, but yes, we do absolutely follow up with the midwives that have not reported.
Yeah. So that leaves, because there was, what was it in total? Well, we can't discuss it right now. What do the members think? Do we want to put this, a discussion of this on the agenda?
We do have the LMAR update. We do have the LMAR update on the agenda. I don't know if that would be sufficient.
Okay. All right. Let's just keep it under that, and I will make a note that to focus on the ones that weren't complete.
Are we
I think we have discussed this in the past.
Yes, we discuss it every time a report comes out.
Maybe we can review what we discussed and what we decided instead of discussing, well, yeah, every time a report comes out, okay. I don't feel like we need to discuss it again unless, I mean.
Well, I think in the past we've discussed that people aren't filling it out and that makes our numbers not look as reliable, but we haven't actually talked strategies for encouraging midwives to submit in a timely way.
I think we have. I feel like we have.
You do? Okay.
I mean, I'm open to it. I think it's redundant, but you know, maybe somebody will have a great idea that no one's thought of before.
All right. Well, let's just look at it next time with the report and the LMAR update, and then we can see if the numbers warrant further action.
Okay.
Ms. Holzer, this is Marina. If I may just ask a question on that agenda item. For the LMAR update, and Tanya, you can correct me if I'm wrong here. I think the LMAR update on the agenda is for the LMAR regs, to provide you a status update on how those regs are moving forward. I don't was this for a separate LMAR update as far as, you know, further discussion on what, you know, the members have been discussing as far as, you know, getting awareness out there to the LMs and, you know, how can we, you know, better inform them of the requirement or follow up or et cetera?
Yep, that's true. You are right. The LMAR update is about the regulatory language.
It just sounded like maybe this could be a separate item if that's what the members chose to, you know, if you want to discuss that.
Okay, well, let's have that as a separate item then on the agenda to discuss we can take a look at what the numbers actually look like of people who are actually practicing in the state and aren't filling it out, and see if we need to do anything.
Okay, thank you.
Okay. Okay, any other comments at all, public or members? No. I think we really can adjourn this time. All right, good to see you all, and we'll see you at the next one.